majority of the people attending are not surgeons, and this is a talk that will help the non-surgeon understand what the state of the art is in technology and lower extremity revascularization. Bill Pevec is going to talk about using intraoperative and other imaging technologies for optimizing results of bypasses. And it's also for the surgeons. This is a little bit of how he does it and the state of the art in Bill Pevec's operating room, which puts the bar pretty high.
Thanks, Dave. I have no disclosures, but I do have a couple complaints. Every year I ask Dave not to give me the boring old-fashioned surgery topic, and I ask him not to put me on the program after a masterful presenter like John Laird, and the program comes out, and I feel like this guy. But anyway, as anyone who does infrainguinal vein grafts know, it's a very unforgiving procedure. You really have to have a perfect reconstruction. One tiny imperfection can ruin the entire operation. The pitfalls include an intrinsic problem with the vein used for the conduit, a problem with the anastomotic technique, problems with either the inflow or the outflow arteries, external compression of the vein, or a kinked or twisted vein from a tunnel problem. And as I said, a single focal defect can ruin an otherwise really good operation. So you can spend 6 or 7 hours doing a bypass and have made one second mistake and the whole thing doesn't work. So you really have to make these perfect. And I think it's even more important in the current day and age. I went back and looked at my own experience, went back arbitrarily 10 years and looked at the number of vein grafts I did, virtually all for critical limb ischemia. I don't treat many patients for claudication with arterial disease below the groin. And I compared 2000 to 2010. And my vein bypass practice has almost gone away as I've shifted to an endovascular approach to these patients. You do a few of these procedures, you're not as good at them anymore. So I think it's really important for surgeons who have a combined endovascular and open practice that they really pay attention to things to optimize perfection with their open bypass case volumes. So the algorithm I recommend, again, this is not based on data, this is just my own bias, is it's really important to do excellent preoperative evaluation, which includes a high-quality arterial diagnostic study, either use a CT angiogram, MRA, or a good catheter-based arteriogram, and then also to do duplex ultrasound evaluation to find the optimal vein conduit. And then the other component I think is very important is the intraoperative assessment, because again, these procedures are totally unforgiving of any minor defect. And that includes, I'm a strong proponent of angioscopy of the vein, which is a technique which is not widely applied these days, and then always some sort of completion study, either a duplex scan or an arteriogram. I'm going to go over angioscopy a bit because, again, I don't think too many surgeons use this technique, and I think it really is very valuable. The components include a fiber optic scope, which includes both an illuminating bundle and then a visual bundle. Very delicate scopes. We use disposable angioscopes, which are really a huge advantage because they don't last. The old reusable ones we used in the distant past just don't hold up. You need a light source, an infusion pump, and then a video camera with a high-resolution monitor. The advantage of angioscopy is twofold. One is to assess the quality of the vein. You'll frequently have a vein that will look good on duplex scan, it'll look good on external inspection, but then when you want to use the vein, you'll find out it fails because either there are some residual valves that are thickened and don't open, or they're webs from previous recanalization of prior thrombus. This is an intraoperative photograph. You can see the red arrow is pointing to a small web. It's a recanalized segment. Small web like this, you can actually take your valvulars home, which is a silver instrument you see there, and under angioscopic guidance, you can divide those webs. But if you have the choice, you're better off using a vein segment that has none of those type of defects. And this is another intraoperative image showing a chronic thrombus adherent to the wall of the vein. In addition to assessing for underlying defects in the vein, angioscopy is also very helpful if you are going to do valvulotomy. I tend to use most of my veins in a non-reverse direction. I've never been able to get good enough to figure out how to anastomose a small vein to a big artery. So I like to have the sizes match up. So either use an in situ technique or a non-reverse transpose technique. And as the imaging is showing here, you introduce the angioscope in a retrograde direction, and then you can use that to guide the lysis of the valves. This is an intraoperative photo of an angioscopic image of a vein valve open, you use a little gentle flow through the irrigation system of the angioscope, and it closes the valve, and then you can come up the other direction and engage the valve with a valvulotome, the arrow showing a valve that's been adequately lysed. You don't actually remove the valves. What you need to do is just render them incompetent, and it's entirely important that you lyse that valve all the way to the wall of the vein. If you leave a little residual cuff on the edge of the vein, if you don't get it cut all the way to the wall here, that's enough to cause the whole reconstruction to fail. The other place where the angioscope really helps, it's quite easy to get the valvulotome caught into a side branch and tug and pull that and damage the vein, and really it's very unforgiving of those type of injuries. Again, not a whole lot of data to support this. This is an old study, and what it shows here is they took patients and they just reviewed their series of ones that used angioscopy on them and the patients they didn't. The assisted primary patency was was not different between the two groups, but the group with angioscopy did not require many revisions to keep the vein graft open. It looked like about 30% of the patients without angioscopy, actually some defect was left behind that could have been fixed in the OR. Granted, the surgeon was able to come back with a secondary procedure and fix that defect, but I think if you can identify these up front, your patients appreciate it and your outcomes are going to be better. I think angioscopy is vital when you're using an arm vein for a conduit. The arm veins are frequently accessed in our patients. These are old patients who have a lot of comorbidities. They've been in the hospital a lot. They've had a lot of IVs. And this is a report from the New England Deaconess Hospital with a very large diabetic population, uses a lot of arm veins for the grafts, and they found a significant incidence of interluminal defects in those arm veins. So you can find those with angioscopy. If they're mild, you can correct them, and if they're major, you'll find another segment of vein to use. Then the last intraoperative step that I strongly recommend, I'm going to go over this a little bit because I think this is a really important adjunct to getting perfect bypasses, is doing a completion intraoperative duplex scan. It has the advantage over arteriography of no contrast. You don't have to disrupt your field. You don't have to puncture any artery or your graft. Very high resolution with the current duplex scanners. In addition to giving just anatomic information, it gives you flow information, which is probably the more important question with vein grafts. And most of us follow our vein grafts post-operatively with duplex scanning, so this is you're using the like modality intraoperatively to give that first assessment. You see a problem on your subsequent follow or difference on your subsequent follow-up study, you know that something's changed, it's not something you just left behind. There are some disadvantages, though. You're basically limited to your sterile field. You can't duplex through the drapes, and so you're limited to what you have exposed. And obviously it requires to have an available duplex scanner. Really requires to have somebody else to help you, because you can certainly do the scan, but you can't adjust the images or do any of the work on the keyboard, so you really need an assistant. And it's really nice if you can get technologists come down and do the scan for you also. Lots of different things that you can pick up on a duplex evaluation of the reconstruction. You can find residual stenosis or fibrosis in the vein if you didn't do angioscopy. You can find incomplete valve lysis, particularly if you did it in a typical blind technique. You can find fibrin platelet aggregates, which can form in the vein during the procedure and can lead to early thrombosis. You can clearly find problems with the anastomoses. You can find clamp injury, particularly at the inflow or the outflow arteries. You can find problems with the inflow or outflow arteries that may have been previously undetected. And you can look at a low flow, detect low flow velocity throughout the graft, which can suggest that you either have a inadequate conduit or more likely inadequate arteries above or below your reconstruction. This is just a picture of the typical scene in the OR, covering up the probe, getting ready to go. As opposed to carotid duplex scan intraoperatively is really more dependent on the B mode, I think. You can see the defects in the carotid artery that you need to correct. For the lower extremity, it's really much more dependent on the spectral analysis of the blood flow. And you really want to do a complete study. You want to see as much, at least want to see a segment of the inflow artery. You want to look at the entire graft, including the anastomoses, and you want to look at the outflow artery. The things that you can find with reversed or translocated vein where you've taken it and put it through a tunnel, there's a risk of a compression or a kink that you might not otherwise detect, that you'll see with elevation in velocity. And it's really helpful for in situ grafts to identify side branches, or for in situ grafts or non-reverse grafts to find residual valves that have not been completely lysed. This is just a B mode image showing an incompletely lysed valve. You can still see an intact valve leaflet, pretty obviously there. The flow patterns you'll see intraoperatively are different than what you're going to see in a typical post-op study. What you want to see on your intraoperative study is a low resistance signal with a significant flow throughout diastole. So in a bypass graft you're going to look at months later, you may not want to see a monophasic waveform like that because that may suggest that there's an inflow problem. But intraoperatively, if you don't see high flow throughout diastole, that suggests the patient has inadequate outflow bed. That graft's probably going to fail. So this is a pattern you want to see ideally in a well-functioning bypass graft. A low-flow graft is a predictor of early failure with a diffuse peak systolic velocity below 40 centimeters per second throughout the graft, because that can imply either inadequate inflow or inadequate outflow. There's just not enough volume flow through the graft. However, that's with a caveat that you'll see diffusely low velocities throughout a graft if the graft diameter is significantly larger than the outflow artery. So if you're lucky enough to have a patient with a 4 or 5 millimeter vein that you sewed into a 2 millimeter tibial artery, they're going to be low velocity flows throughout that graft. That's okay. But if you have a pretty even size match between the vein and the outflow artery, and you have diffusely low flow velocities throughout the graft, there's a problem someplace, either at the inflow or the outflow artery. There have been published criteria of how to define a stenosis. The most common thing you're going to detect on the duplex scan is a stenosis, either in the graft itself from a problem with a web or a valve, or a problem at the anastomosis. The bottom line is a peak systolic velocity greater than 180 centimeters per second, or a velocity ratio from proximal to the defect to distal to it, where the velocity increases by a factor of 2.5 to 4, are the ones that you need to intervene on right at that time. It takes obviously some experience and judgment to really pick out which defects you need to intervene on, but clearly patients who have significant increases in the velocity ratio in a focal area probably need to be revised if you want to have a successful bypass. You can also, with the completion duplex scan, if you use an in situ technique, identify residual arteriovenous fistulae, residual vein branches that you have not ligated. You can sometimes see the branch itself with color flow Doppler. If there's an AV fistula, you'll see unusually low resistance proximal to the fistula and then higher resistance distal to it. Not all of them need to be corrected, but some of these can compromise graft flow. This is just an example of the sample volumes here looking right at the AV fistula. You can see turbulent flow on the color mapping, and you can see this very turbulent flow, high resistance turbulent flow, a lot of spectral broadening, high diastolic flow, and this is proximal to the AV fistula where this sample volume was taken. And this is actually that was right at the fistula. This is the same graft, and this is proximal to the graft where there's a lot of end diastolic flow and a lot of turbulence, and proximal to the fistula, and then distal to the fistula, that turbulence has gone away, the spectral broadening's gone away, there's a nice window, and you still have good end diastolic flow, but not quite at the same velocity as you had more proximally. The hardest thing on the intraoperative duplex scan is to figure out when there's a high velocity at the distal anastomosis, is that an anastomotic problem or is that just spasm in the artery? If you're sewing particularly tibial arteries, they tend to spasm just from the surgical manipulation. You get high velocities, and at first if you just react to velocity, you end up operating on, or at least get an arteriogram on every distal anastomosis because they all have high velocities. So certainly if you see a defect on the B mode image, that sees some narrowing, you see a flap, that's one thing that suggests a stenosis. But just a velocity, and if there's a focal elevation of the velocity with the defect on the image, that suggests there's a problem. And this is an example of a patient with a stenosis at the distal anastomosis. You can see, it looks like there's a defect here. The hood of the graft is pulled in a little bit. There's a lot of turbulence here, and there's a high systolic velocity of over 250 centimeters per second. Spasm, as opposed to a focal defect, you'll see a more diffuse elevation of the velocity, and that velocity will stay elevated into the outflow artery. And this is an example on the color flow B mode imaging. And this is a distal anastomosis to a tibial artery. Again, it looks nice here. You don't see anything that looks bad. And the velocities are elevated not only at the distal anastomosis, but in the dorsopedial artery, or in the distal outflow artery. This is dorsopedial artery. And a couple centimeters farther out in the artery, the velocities remain elevated. So that's probably more spasm than a defect. And finally, I personally don't use completion arteriography for a typical bypass, although it's certainly a reasonable choice. I clearly would use it, though, anytime you're doing a hybrid procedure or you're doing you're going to use imaging anyway. So a patient who's having a thrombectomy or embolectomy for acute ischemia, or if you're doing a hybrid procedure where you're doing partial endovascular recanalization and a bypass, the patient's already on the angio table, you might as well go ahead and get the completion arteriogram. And this is just an example of a patient. This patient actually turns out had a synthetic bypass graft, but we then did angioplasty of the anterior tibial and perineal arteries, as well as the completion arteriogram at the end of the procedure. So in summary, the algorithm is to get high-quality diagnostic arterial study, imaging study to select the right inflow and outflow sites, good preoperative ultrasound to get the best vein, use angioscopy to optimize the conduit, use a completion duplex scan or an arteriogram at the end of the procedure. With this algorithm, I've been able to virtually eliminate take-back for early problems. Grafts still fail late, but you don't take them back that night. And I think it also minimizes early graft revisions within the first few months. And I would say that if you don't use imaging techniques for your bypass, you're basically operating blind. Thank you. The boring old-fashioned surgery topic, and I ask them not to put me on the program after a masterful presenter like John Laird, and the program comes out, and I feel like this guy. But anyway, as anyone who does infralinguinal vein grafts know, it's a very unforgiving procedure. You really have to have a perfect reconstruction. One tiny imperfection can ruin the entire. More important in the current day and age. I went back and looked at my own experience, went back arbitrarily 10 years and looked at the number of vein grafts I did, virtually all for critical limb ischemia. I don't treat many patients for claudication with arterial disease below the groin. And I compared 2000 2010. And my vein bypass practice has almost gone away as I've shifted to an endovascular approach to these patients.
Revascularization. Bill Pevec is going to talk about using intraoperative and other imaging technologies for optimizing results of bypasses. And it's also for the surgeons. This is a little bit of how he does it and the state-of-the-art in Bill Pevec's operating room, which puts the bar pretty high.
Thanks, Dave. I have no disclosures, but I do have a couple complaints. Every year I ask Dave not to give me
The majority of the people attending are not surgeons, and this is a talk that will help the non-surgeon understand what the state-of-the-art is in technology and lower
operation. The pitfalls include an intrinsic problem with the vein used for the conduit, a problem with the anastomotic technique, problems with either the inflow or the outflow arteries, external compression of the vein, or a kinked or twisted vein from a tunnel problem. And as I said, a single focal defect can ruin an otherwise really good operation. So you can spend 6 or 7 hours doing a bypass and have made one 1-second mistake and the whole thing doesn't work. So you really have to make these perfect. And I think it's even more